हाय एवरीवन, वेलकम बैक्स टू अनदर वीडियो। ठीक है, तो आज हमारा बुक रीडिंग सेशन में हैरिसन प्रिंसिपल ऑफ इंटरनल मेडिसिन जो होता है पेन सेक्शन में हमने यहाँ तक टोटली मतलब पढ़ लिया था। नाउ इस चैप्टर को हम कई बार पढ़ेंगे ताकि हमें चीज़ें सभी लाइन बाय लाइन और सेंटेंस बाय सेंटेंस मीनिंग समझ आ जाए। ठीक है, तो यहाँ तक हमारा एंड था। हमने डेट भी मेंशन किया था कि हमने इसे कब पढ़ा था। 25/11/26 को हमने पढ़ा था। ठीक है, नाउ आज स्टार्ट करेंगे ओपियाइड एंड कॉक्स इनहिबिटर कॉम्बिनेशन। When used in combination, opioid and COX inhibitor have additive or synergistic effect because a lower dose of each can be used to achieve the same degree of pain relief, and their side effects are typically dose related. Such combinations are used to lower the severity of dose related side effect. However, fixed ratio combination of an opioid with acetaminophen carry an important risk dose escalation because of increased severity pain or decreased opioid effect. As a result of tolerance may lead to ingestion level of acetaminophen that are toxic to the liver. Although acetaminophen related hepatotoxicity is uncommon, it remains a significant cause for liver failure. Thus, many practitioners have moved away from the use of opioid acetaminophen combination analgesic to avoid the risk of excessive acetaminophen exposure as the dose of analgesic is escalated. Chronic pain. Chronic pain. Managing patient with chronic pain is intellectually and emotionally challenging. Sensitization of the nervous system can occur without an obvious precipitating cause. Example, fibromyalgia or chronic headache. In many patients, chronic pain becomes a distinctive disease unto itself. The pain generating mechanism is often difficult or impossible to determine with certainty. Such patients are demanding of the physician time and often appear emotionally distraught. The traditional medical approach of seeking an obscure organic pathology is often unhelpful. On the other hand, psychological evaluation and behaviorally based treatment paradigms are frequently helpful, particularly in the setting of a multidisciplinary pain management center. Unfortunately, this approach, while effective, remains largely underused in current medical practice. There are several factors that can cause, perpetuate, or exacerbate chronic pain. First, of course, the patient may simply have a disease that is characteristically painful for which there is presently no cure. Arthritis, cancer, chronic daily headache, fibromyalgia, and diabetic neuropathy are examples of this. Second, there may be a secondary perpetuating factor that are initiated by disease and persist after that disease has resolved. Example include damaged sensory nerve, sympathetic efferent activity, and a painful reflex muscle contraction, matlab spasm. Finally, a variety of psychological condition can exacerbate or even cause pain. There are certain areas to which special attention should be paid in the patient medical history. ओके 1 मिनट थोड़ा स्टॉप वॉच को लगाने दीजिए. Because depression chapter number 463 is the most common emotional disturbance in patient with chronic pain, patient should be questioned about their mood, appetite, sleep pattern, and daily activity. A simple standardized questionnaire such as the Bake Depression Inventory can be useful screening device. It is important to remember that major depression is a common, treatable, and potentially fatal illness. Other clues that a significant emotional disturbance is contributing to a patient's chronic pain complaint include pain that occurs in multiple unrelated sites, a pattern of recurrent but separate pain problems beginning in childhood or adolescence, pain beginning at a time of emotional trauma such as the loss of a parent or spouse, a history of a physical or sexual abuse, and past or present substance abuse. On examination, special attention should be paid to whether the patient guards the painful area and whether certain movement or posture are avoided because of pain. Discovering a mechanical component to the pain can be useful both diagnostically and therapeutically. Painful areas should be examined for deep tenderness, noting whether this is localized to muscle, ligamentous structure, or joint. Chronic myofascial pain is very common, and in these patients, deep palpation may reveal highly localized trigger point that are firm band or not in the muscles. Relief of pain following injection of local anesthetic into these trigger points supports the diagnosis. A neuropathic component to the pain is indicated by the evidence of nerve damage, such as sensory impairment, exquisitely sensitive skin, मतलब allodynia, weakness, muscle atrophy, or loss of deep tendon reflex. Evidence suggesting sympathetic nervous system involvement include the presence or of a diffuse swelling, changes in skin color and temperature, and hypersensitive and joint skin and joint skin and joint tenderness compared with the normal side. Relief of pain with a sympathetic block support the diagnosis, but once the condition become chronic, the response to sympathetic blockade is of a variable magnitude and duration. The role of for repeated sympathetic block in the overall management of a CRPS is unclear. A guiding principle is evaluating patient with chronic pain is to assess both emotional and somatic causal and perpetuating factor before initiating therapy. Addressing these issues together rather than waiting to address emotional issue after somatic cause of pain have been ruled out. Improve compliance in part because it assures patient that a psychological evaluation does not mean that the physician is questioning the validity of their complaint. Even when a somatic cause for a patient's pain can be found, it is still wise to look for other factors. For example, a cancer patient with painful bony metastate may have additional pain due to nerve damage and many may also be depressed. Optimal therapy requires that each of these factors be assessed and treated. ट्रीटमेंट क्या? अगर क्रोनिक पेन होगा, once the evaluation process has been completed and the likely causative and exacerbating factor identified, an explicit treatment plan should be developed. An important part of this process is to identify specific and realistic functional goal for therapy, such as getting a good night's sleep, being able to go shopping, or returning to work. A multidisciplinary approach that uses medication, counseling, physical therapy, nerve block, and even surgery may be required to improve the patient's quality of life. There are also some newer, mainly invasive procedures that can be helpful for some patients with intractable pain. These include image guided interventions such as epidural injection of glucocorticoids for acute radicular pain and radiofrequency treatment of the facet joint for chronic facet related back and neck pain. For patient with severe and persistent pain that is unresponsive to more conservative treatment, placement of electrode on peripheral nerve or within the spinal canal or on nerve root or in the space overlying the dorsal column of the spinal cord, that is spinal cord stimulation, has shown significant benefit. The criteria for predicting which patient will respond to these procedures continue to evolve. They are generally reserved for patients who have not responded to the conventional pharmacologic approaches. Referral to a multidisciplinary pain clinic for a full evaluation should precede any invasive procedure. Such referrals are clearly not necessary for all chronic pain patients. For some, pharmacologic management alone can provide adequate relief. Antidepressant medication. The tricyclic antidepressant, that is TCA, particularly nortriptyline and desipramine table 14-1, are useful for the management of a chronic pain. Although developed for the treatment of a depression, the tricyclic antidepressant have a spectrum of dose-related biologic activities that include analgesia in a variety of chronic clinical conditions. Although the mechanism is unknown, the analgesic effect of a TCA has a more rapid onset and occurs at a lower dose than is typically required for the treatment of a depression. Furthermore, patients with chronic pain who are not depressed obtained pain relief with antidepressant. There is evidence that TCA potentiate opioid analgesia, so they may be useful adjunct for the treatment of severe persistent pain such as occur with malignant tumor. Table 14.2 lists some of the painful conditions that respond to the TCA. TCA are of particular value in the management of neuropathic pain such as occur in the diabetic neuropathy or post therapeutic neuralgia. Post 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 okay sorry post herpetic neuralgia, for which there are few other therapeutic options. The tricyclic antidepressant that have been shown to relieve pain have significant side effect. Table 14.1, chapter number 463, 463. Some of these side effects such as orthostatic hypotension, drowsiness, cardiac conduction delay, memory impairment, constipation, and urinary retention. Urinary retention. Okay, are particularly problematic. Are particularly problematic in elderly patient, and several are additive to the side effect of opioid analgesic. Now यहाँ से थोड़ा टेबल 14.2 हम पढ़ लेते हैं. पेनफुल condition that respond to tricyclic antidepressant, that is TCA. So post herpetic neuralgia, diabetic neuropathy, fibromyalgia, tension headache, migraine headache, rheumatoid arthritis, chronic low back pain, cancer, सेंट्रल पोस्ट स्ट्रोक पेन. यहाँ पर जो ए सभी में मेंशन है, कंट्रोल ट्रायल डेमोन्स्ट्रेट एनाल्जेसिया. कंट्रोल ट्रायल डेमोन्स्ट्रेट एनाल्जेसिया. बी हो गया आपका कंट्रोल स्टडीज इंडिकेट बेनिफिट बट नॉट analgesia. Okay. The selective serotonin reuptake inhibitors such as fluoxetine have fewer and less serious side effects than TCA, but they are much less effective for relieving pain. In contrast, venlafaxine and duloxetine, which are tricyclic antidepressant that block both serotonin and norepinephrine reuptake, appears to retain most of the pain relieving effect of TCA with a side effect profile more like that of the selective serotonin reuptake inhibitor. Because of their favorable adverse effect profile, these drugs have largely supplanted the use of TCA in the treatment of chronic pain. Anticonvulsant and antiarrhythmic. These drugs are useful primarily for patients with neuropathic pain. Phenytoin and carbamazepine were first shown to relieve the pain of trigeminal neuralgia, chapter number 452. This pain has a characteristic brief shooting electric shock-like quality. In fact, anticonvulsants seem to be particularly helpful for pain that have such a lancinating quality. Newer anticonvulsant, the calcium channel alpha 2 delta subunit ligand, gabapentin, and pregabalin, are effective for a broad range of neuropathic pain. Furthermore, because of their favorable side effect profile, these newer anticonvulsants are often used as first-line agent. Cannabinoids. ମୋ ଆଈକୁ ତାହେଲେ ଏଇରା ହେଉଛି. ଏଇ କେସ୍ରେ ତ ଗାବାପେଣ୍ଟିନ୍ ଦିଆଯାଉଥିଲା, ଲେକିନ୍ ତାର ମୁଣ୍ଡ ବୁଲଉଥିଲା କହୁଥିଲା। ମୁଣ୍ଡ ବୁଲଉଥିଲା, ଗାବାପେଣ୍ଟିନ୍ ତ ଦିଆ ହେଉଥିଲା, ପ୍ରେଗାବାଲିନ୍ ତ ଦିଆ ହେଉଥିଲା, କିନ୍ତୁ ତା ମୁଣ୍ଡ ବୁଲଉଥିଲା, ପଡ଼ି ଯାଉଥିଲା। ଦେଖିବା ଆଉ ଟିକେ ଅଧିକ ପଢ଼ିଲେ ଜଣାପଡ଼ିବ ଆଉ। Cannabinoids. These agents are widely used for their analgesic properties, although published evidence suggests that any analgesic effects are modest, with small increase in pain threshold reported and variable reduction in clinical pain intensity. Cannabis more consistently reduce the unpleasantness of the pain experience, and in cancer related pain can lessen the nausea and vomiting associated with chemotherapy use. Marijuana and related compound are discussed in chapter number 466. Chronic opioid medication. The long-term use of opioid is accepted for patients with pain due to malignant disease. Although opioid use for chronic pain of non-malignant origin is controversial for many patients, opioids are the only option that produces meaningful pain relief. This is understandable because opioids are the most potent and have the broadest range of efficacy of any analgesic medication. Although addiction is rare in patients who first use opioid for pain relief, some degree of tolerance and physical dependence is likely with long-term use. Furthermore, studies suggest that long-term opioid therapy may worsen patient in some individuals, termed opioid-induced hyperalgesia. Hyperalgesia. Therefore, before embarking on opioid therapy, other options should be explored, and the limitation and risk of opioid should be explained to the patient. It is important to recognize that some opioid analgesic medication have mixed agonist antagonist properties, example butorphanol and buprenorphine. For a practical standpoint, this means that they may worsen pain by inducing an abstinence syndrome in patients who are actively being treated with other opioids and are physically dependent. With long-term outpatient use of orally administered opioid, it may be desirable to use long-acting compounds such as methadone, extended-release morphine, or oxycodone, or transdermal fentanyl. Table 14.1. The pharmacokinetic profile of these drug preparation enable the maintenance of a sustained analgesic blood vessel, potentially minimizing side effects such as sedation that are associated with high peak plasma level and reducing the likelihood of rebound pain associated with a rapid fall in plasma opioid concentration. Extended release opioid formulation are approved primarily for patients who are already taking other opioid and should not be used for the first line opioid for pain. Although long-acting opioid preparation may provide superior pain relief in patients with continuous pattern of ongoing pain, others suffer from intermittent severe episodic pain and experience superior pain control and fewer side effects with the periodic use of short-acting opioid analgesic. Constipation is a virtually universal side effect of opioid use, and should be treated expectantly. As noted earlier in the discussion of acute pain management and advance for patient in the development of a peripherally acting opioid antagonist that can reverse the constipation associated with opioid use without interfering with analgesia. Soon after the introduction of an extended release oxycodone formulation in the late 1990 century, a dramatic rise in the emergency department visit and death associated with oxycodone ingestion appeared. This appeared to be due primarily to individual using a prescription opioid non-medically. Drug-induced deaths have rapidly risen and are now second leading cause of death in Americans, just behind motor vehicle fatalities. In 2011, the Office of National Drug Control Policy established a multifaceted approach to address prescription drug abuse, including prescription drug monitoring program, that is PDMP, that allows practitioner to determine if patients are receiving prescription from multiple providers, the and use of law enforcement to eliminate improper prescribing practice. In 2016, the Center for Disease Control and Prevention, that is CDC, released the CDC guideline for prescribing opioid for chronic pain with recommendation for primary care with recommendation for primary care clinician who are prescribing opioid for chronic non-cancer pain. A modified approach to opioid prescribing was published in 2019 by the Health and Human Service Task Force on Chronic Pain, Best Medical Practice, and updated in 2022. These guidelines address: number 1, when to initiate or continue opioid for chronic pain, opioids selection, dosage, duration, follow up, and discontinuation. And number 3, assessing risk and addressing harms of opioid use. The recent increase in scrutiny leaves many practitioners hesitant to prescribe opioid analgesic other than for brief period to control pain associated with illness or injury. For now, the choice to begin chronic opioid therapy for a given patient is left to the individual practitioner. The new CDC guideline aim to help practitioners reduce the risk of opioid misuse and overdose death while providing effective pain management for their patient. Pragmatic guidelines for properly selecting and monitoring patients receiving chronic opioid therapy are shown in Table 14.3. A checklist for primary care clinician prescribing opioid for non-cancer pain is shown in Table 14.4. Practitioners should refer to the 2022 Clinical Practice Guideline for prescribing opioid for pain referenced in further reading below. Opioid use disorder are comprehensively discussed in chapter number 467. Treatment of neuropathic pain. It is important to individualize treatment for patients with neuropathic pain. Several general principles should guide therapy. The first is to move quickly to provide relief, and the second is to minimize drug side effect. For example, in patients with post herpetic neuralgia and significant cutaneous hypersensitivity, topical lidocaine can provide immediate relief without side effect. The anticonvulsant gabapentin or pregabalin or pregabalin, see above, or antidepressant nortriptyline, desipramine, duloxetine, or venlafaxine can be used as a first-line drug for patient with neuropathic pain. Okay. तो टेबल थोड़ा देख लेते हैं. टेबल 14.3 गाइडलाइन फॉर सिलेक्टिंग एंड मॉनिटरिंग पेशेंट रिसीविंग क्रोनिक ओपियोइड थेरेपी दैट इज COT for the treatment of a chronic non-cancer pain. Patient selection: conduct a history, physical examination, and appropriate testing, including an assessment of a risk of substance abuse, misuse, or addiction. Consider a trial of a COT chronic opioid therapy. Chronic opioid therapy if pain is moderate or severe, pain is having an adverse impact or function or quality of life, and a potential therapeutic benefit outweighs potential harm. A benefit to harm evaluation, including a history, physical examination, and appropriate diagnostic testing, should be performed and documented before and on an ongoing basis during COT मतलब chronic opioid therapy. Informed consent and use of a management plan. Informed consent should be obtained. A continuing discussion with the patient regarding chronic opioid therapy should be include goal, expectation, potential risk, and alternative to chronic opioid therapy. Consider using a routine chronic opioid therapy management plan to document patient and clinician responsibilities and expectation and assist in patient education. Initiation and titration. Initial treatment with opioid should be considered as a therapeutic trial to determine whether chronic opioid therapy is appropriate. Opioid selection, initial dosing, and titration should be individualized according to the patient health status, previous exposure to opioid, attainment of therapeutic goals, and predicted or observed harm. Monitoring. Release patient on chronic opioid therapy periodically and as warranted by changing circumstances. Monitoring should include documentation of pain intensity and level of functioning, assessment of progress towards achieving therapeutic goals, presence of adverse event, and adherence to prescribed therapies. In patients on chronic opioid therapy who are at high risk or who have engaged in aberrant drug related behavior, clinicians should periodically obtain urine drug screen or other information to confirm adherence to the chronic opioid therapy plan of care. In patient on chronic opioid therapy not at a high risk and not known to have engaged in aberrant drug related behavior, clinicians should consider periodically obtaining urine drug screen or other information to confirm adherence to the chronic opioid therapy plan of care. Source: reproduced with permission from the ଏତିକି clinical guideline for the use of a chronic opioid therapy in chronic non-cancer pain. Okay. Systematically administered anti-arrhythmic drugs such as lidocaine and mexiletine mexiletine are less likely to be effective, although intravenous infusion of lidocaine can provide analgesia for patients with different type of neuropathic pain. The relief is usually transient, typically lasting just After the cessation of the infusion, the oral lidocaine congener mexilatin is poorly tolerated, producing frequent gastrointestinal adverse effect. There is no consen- consensus on which class of drug should be used as a first line treatment for any chronically painful condition. However, because relatively high dose of anticonvulsant are required for pain relief, sedation is not uncommon. Sedation is also a problem with tricyclic antidepressant but is much less of a problem with serotonin norepinephrine reuptake inhibitor, that is SNRI. Example venlafaxine and duloxetine. Thus, in the elderly or in patients whose daily activities require high level mental activity, these drugs should be considered the first line. In contrast, opioid medication should be used as a second or third line class drug. Although high effective for many painful conditions, opioids are sedating and their effect tends to lessen over time, leading to dose escalation and occasionally worsening of pain. A couple of interesting alternatives to pure opioid are two drugs with mixed opioid and norepinephrine reuptake action, tramadol and tapentadol. Tramadol is a relatively weak opioid but is sometimes effective for pain unresponsive to non-opioid analgesic. Tapentadol is a stronger opioid but its analgesic action is apparently enhanced by the norepinephrine reuptake blockade. अरे ये क्या हो रहा है? रीअपटेक इनमेट चेस्ट डिस्कम्फर्ट उसके बाद अच्छा ये आज पूरा ख़त्म हो जाएगा ये चैप्टर तो ख़त्म कर देते हैं. Table 14.4 Center for Disease Control and Prevention Checklist for Prescribing Opioid for Chronic Pain. For primary care provider treating adult को treat करोगे 18 years with chronic pain. chronic pain हम किसको कहेंगे ना ग्रेटर दैन 3 months से अगर हो रहा है, एक्सक्लूडिंग आपका इसमें कैंसर आएगा, पैलिएटिव आएगा, एंड ऑफ लाइफ केयर. Checklist when consider long-term opioid therapy. Set realistic goal for pain and function based on diagnosis. Example, walk around the block. Check that non-opioid therapy tried and optimized. Discuss benefit and risk. Example, addiction overdose with the patient. Evaluate risk of harm or misuse. Discuss risk factor with patient. Check prescription drug monitoring program data. Check urine drug screen. Set criteria for stopping or continuing opioid. Assess baseline pain and function. Example, pain, enjoyment, general activity, that is PEG scale. Schedule initial reassessment within 1 से लेकर के 4 week. Prescribe short acting opioid using lowest doses on product labeling. Match duration to scheduled reassessment. If renewing without a patient visit, check that return visit is scheduled less than 3 months from the last visit. When reassessing at a patient visit, continue opioid only after confirming clinical meaningful improvement in pain and function without significant risk or harm. Assess pain and function. Example, PEG, compare results to baseline. Evaluate risk of harm or misuse. Observe patient for sign of over sedation or overdose risk. If yes, taper dose. Check PDMP. Check for opioid use disorder if indicated. Example, difficulty controlling use. If yes, refer for treatment. Check that non-opioid therapy optimized. Determine whether to continue, adjust, taper or stop opioid. Calculate opioid dose morphine milligram equivalent, that is morphine milligram equivalent. If greater than 50 morphine मिलीग्राम इक्विवेलेंट पर डे टोटल अगर रहेगा तो ग्रेटर देन 50 mg ऑफ हाइड्रोकोडोन, greater than equals to 33 mg oxycodone. Increase frequency of follow-up. Consider offering naloxone. Avoid greater than equals to 90 morphine milligram equivalent per day total, that is greater than equals to 90 mg hydrocodone, greater than equals to 60 mg oxycodone, and carefully justify. Consider a specialist referral. Schedule reassessment at regular interval, that is लेस देन आपका 3 मंथ होना चाहिए. सोर्स सेंटर फॉर डिजीज कंट्रोल एंड प्रिवेंशन अवेलेबल एट स्टैक्स CDC. ओके, पब्लिक डोमेन में ये सब अवेलेबल है. ओके. Similarly, drug of different classes can be used in combination to optimize pain control. It is worth emphasizing that many patients, especially those with chronic pain, seek medical attention primarily because they are suffering and because only physician can provide the medication required for pain relief. A primary responsibility of all physicians is to minimize the physical and emotional discomfort of their patient. Familiarity with pain mechanism and analgesic medication is an important step towards accomplishing this aim. Further reading. फर्दर रीडिंग में क्या, एसोसिएशन ऑफ कैनाबिनॉइड एडमिनिस्ट्रेशन विथ एक्सपेरिमेंटल पेन इन हेल्दी एडल्ट, ए सिस्टमेटिक रिव्यू एंड मेटा एनालिसिस. उसके बाद CDC क्लिनिकल प्रैक्टिस गाइडलाइन फॉर प्रिस्क्राइबिंग ओपियोइड फॉर पेन यूनाइटेड स्टेट्स. उसके बाद न्यूरोपैथिक पेन फॉर मैकेनिज्म टू ट्रीटमेंट. ओके. Incidence of and risk factor of chronic opioid use among opioid naive patient in post operative period. ओके. सो आज हमारा यहाँ तक पूरा ख़त्म हो गया. आज का डेट कितना है, 16 फरवरी 2026. टाइम 7:11 PM है. एंड सो हमने पेन के बारे में डिटेल आज पढ़ लिया. इसको कई बार हम क्या करेंगे, बार बार हम इसको, क्योंकि फिगर को भी हमने एनालिसिस नहीं किया था, ऐसे चैप्टर को बहुत बार पढ़ने से पेन का पैथोफिजियोलॉजी एंड मैनेजमेंट, कैसे पेन का पैथोफिजियोलॉजी मतलब पेन कैसे काम करता है, ठीक है, कैसे पेन होता है, इसका फंक्शन क्या होता है एंड इसका मैनेजमेंट कैसे हम कर सकते हैं. तो इसी चैप्टर को कई बार पढ़ेंगे, ठीक है. तो ये आप देख सकते हो, ये पेन पैथोफिजियोलॉजी एंड मैनेजमेंट हमने पढ़ लिया कि कैसे कैसे इसमें पेरिफेरल मैकेनिज्म, पेन सेंसरी सिस्टम, सेंसिटाइजेशन किस तरीके से होता है, सेंट्रल मैकेनिज्म किस तरीके से होता है. तो यहाँ पर बहुत सारा मतलब फंक्शनल मैग्नेटिक रेजोनेंस इमेजिंग डेमोन्स्ट्रेट प्लेसेबो enhanced brain activity in anatomic region correlating with the opioidergic descending pain control system. ये डायग्राम को हमने जानबूझ करके छोड़ा था. डायग्राम को फिर अच्छे से एक्सप्लेन करेंगे। फिलहाल के लिए हम इस चैप्टर को बहुत बार पढ़ेंगे, इतनी बार पढ़ेंगे कि इसकी डाटा पूरा दिमाग में इम्प्रिंट हो जाएगा एंड हम एक बेहतर मेडिकल केयर लोगों को प्रोवाइड कर सकें। इसे बहुत बार पढ़ने पर मतलब समझ आएगा। ओके, ये रहा आज का सिस्टम। थैंक्स फॉर वॉचिंग।